The proceeding is currently in private.
Welcome. First of all, can I say if the gentlemen want to take their jackets off, I will feel more comfortable if you did. So thank you all for coming. Just a few administrative things. The whole session is on record, and when the broadcasting sign is on, we are on now being broadcasted, and any private conversation may be picked up, so please be careful. That goes for committee members as well. Committee members will declare any particular interest when they ask the questions, even though it might already be in the declaration of their interests. And at the end of the session, of course, you will be provided with the transcript, and you can't change it, but you can correct it if you so wish. And before we start, if you're happy, please introduce yourself. And if you want to make an opening statement, please feel free to do so on any aspects of our inquiry. So can I start from my left hand side?
So my name is Chris Hobson. I'm the Chief Executive of NHS Providers, and we're the membership organisation for the 238 acute community mental health and ambulance foundation trusts and trusts. I'll just say literally 5 very, very quick things. Firstly, it seems to us that if you look at the future projections for demand and disease patterns, there is a spike in demand that the NHS faces, which, to be frank, our perception is it's wholly unprepared for. If you then, the second point to make would be linked to that is there clearly is a set of workforce demands that extra demand will create, which again we feel the NHS is wholly unprepared for. The third is that we can't see how the NHS can meet those challenges and the wider social care system within the existing model, and that we therefore need to move to new care models much more rapidly. And we are concerned, although that process has started, we're concerned about the ability of the NHS to get there quickly enough and consistently enough. The fourth point to make is we believe we will need to increase funding, and that actually the current funding levels will be insufficient to meet that demand. And then the final point to make really is that if we're to keep a taxpayer-funded system, we feel very strongly that if there is to be increased funding, it will require public consent. And if we're to gain that public consent, we need a much better quality of debate about the NHS, its funding and its outcomes.
Thank you very much. Mr. Doyle, it's nice to have a previous Secretary of State here.
Not everyone in the room may agree with that, my Lord, but thank you for the invitation. Can I introduce myself as Chair of the NHS Confederation, which also has members from the provider side, but from the commissioning side of the health service. We also have associations with the Local Government Association, and we seek to develop a broad health and care view of the health and care economy. I should declare 2 interests, if I may, to the committee. The first is that I'm an advisor to KPMG, and the second is that I chair Languisson. And I want to refer to that because I want to refer briefly to the report published by the ONS on the total size of the health and care economy, which did rely to some extent on work done by Languisson. And in terms of an opening statement, I think there are 2 points I'd like to make, agreeing with everything Chris has already said. The first is to refer to the total health and care economy, which the report I've already referred to assesses as around 10%, 9.9% to be precise, of the UK economy. This is a reassessment that was published by the ONS earlier this year. To some extent draws the fire on those who draw attention to allegedly how small our health and care sector is by international comparison. We're still, incidentally, 1% behind France and Germany, but significantly higher levels of spend on health and care services than some of the earlier numbers suggested. But it allows me to make what I think is the more important point than the moment in time comparisons on the size of the health and care economy, and that's to refer to trends. And I very much welcome the work of this committee, which, if it's focused on the long-term sustainability of our health and care sector, is presumably focused on the trends of where this is going to over the next 5, 10, 15 years. And I think there's a tendency when people talk about the health and care sector to regard it, because it's largely tax-funded, as a kind of national overhead and a burden. And we're worried because we devote a rising share of our national income to delivering health and care services. I'd like to invite the committee to look at it exactly the other way round, that as society gets richer, of course it's true that the elements of our society that deliver care, health and care services to the sick and the elderly take a rising share of our economy. Why wouldn't they? It's Laszlo's famous hierarchy of need, that a richer society, as societies get richer in this country and all over the world and throughout history, these services take a rising share of our rising national wealth. And the question for this committee and for those who are concerned about the future of this sector, it seems to me, should be how to ensure that that expressed wish of consumers in this and every other country throughout history is not obstructed by the fact that we choose to fund the majority of our services through the tax system in order to secure equitable access. And it's that policy challenge which I think is at the heart of good policy making in the health and care services. How to facilitate the growth rather than, as the government's current plans suggest, restrict that growth, I would argue, artificially during the whole of the current decade. That's the core question. The second question I'd like to touch on briefly during the evidence, if the committee is interested, is not just the quantum of money, but how we ensure that the money is properly spent to deliver the objective of improved life experience for the consumers that I've just been talking about. Because we tend, again, because we think of it as services, to think about medicine and we think about the service that we've delivered over a period of years, rather than the outcome we deliver and the experience of the people who rely on these services. And that's a theme I'd like to come back to.
Thank you. I'll come back to some of the comments you made in the first question, but Mrs. Wilcox.
I'm Margaret Wilcox, and I'm currently the Vice President of the Association of Directors of Adult Social Services, so we represent the directors, both current and past, and the assistant directors in the country. I think my opening remarks would be that we are very well rehearsed in the ageing population that the country faces, and in particular the fact that most of us, many of us, are living longer with more complexities, and the number of over 85-year-olds is a very significant rise for the population. But I think we would want to urge people to consider the fact that there are other groups that are also in that rising group. So there are more people with learning disabilities now and predicted to have 21% more by 2030. There is a rising number of people with mental illness. We've made more mental health act assessments and more deprivation of liberty assessments in the last few years, and they continue to rise year on year. We're seeing dementia in people with learning disabilities, situations that we haven't seen before, and people who, regardless of whether they have a mental health problem or a learning disability problem or indeed a physical disorder, are likely to have more complex needs because of the nature of the advances that we've seen in medicine and indeed to a certain extent in social care. So I would urge the committee to think about the fact that in order for people to have a fulfilled life for as long as they can, then we need a range of services that go across health and social care and into broader areas such as employment, so that people can have a fulfilled life and actually contribute to the economy. So the services that we have, the providers that we have, yes, they do take a form of taxation, but I think it's really important to remember that they also contribute huge numbers to the economy. The social care workforce in this country is bigger than the NHS workforce, and I think people often forget that and the contribution they make back. And the situation that we currently face, which I'm sure will come out in the debate, is about where is that future workforce and what sort of model can we expect for people to have to live at home for as long as they possibly can, or at least in their own community, with the right support, not too much support and enough to be motivated, but enough to keep them safe and as healthy as possible for as long as possible.
Well, thank you, all of you, for that opening statement. And that actually, much of what all of you have said comes out in the first question that I had, which was related to the funding issue for future sustainability, and also the use of the money. So if I go back to that, and all of you may wish to comment, is how do we put health service or spending on health, on all its aspects, as part of the public service agenda? You mentioned, Margaret, about the housing issues as being part. We also heard about integration of social care. So do you have any comment about either of those questions?
Well, I think Stephen should go first because he's very strong on this issue. So I will follow behind you.
Wish to manage expectations, but I think that, if I may say so, my lord, this is at the heart of it. And what I'd like to do is to dive straight into a short-term issue, which is the sustainability and transformation plans, but enlarge that to show how I think that that's where an important part of the longer-term answer lies. Last December, NHS England initiated the STP process, which is variable. It's being, in the famous cliche, built in flight. It's certainly imperfect, but I'm absolutely clear that it's the right direction of travel, because what it's doing is insisting that you can't deliver what I talked about, outcomes for citizens, if you see the NHS either as a single silo or, more accurately, as a group of silos. The NHS is not a city on the hill, is the simple way of putting it. It is a public service, and you can only deliver effective outcomes, good value, high-quality services for citizens if the NHS is part of the broad range of public services delivered in a place. STP is the NHS route into the devolution agenda that was pioneered by Sir Howard Bernstein in Greater Manchester. We're seeking to develop one of my roles as an independent chair in Birmingham and Solihull STP. What we're seeking to do is to insist that the NHS acute hospitals, the NHS primary care, community health services, social care services, social housing services, the education services are all part of a continuum of public services. And if you cut, for example, mental health services in schools, or you cut independent living through the DWP, or you cut extra care housing through the housing budget, then what happens is that the public service economy as a whole shrinks, the outcome delivered to citizens shrinks, and the people become unnecessarily ill. People express this as an economic argument. Actually, the real challenge is the social policy point, that if people aren't able to live independently, they become unnecessarily ill, and they then present in GP surgeries, A&E units and emergency admission wards.
I think another way of saying that is that, the evidence is very, very clear, isn't it? I mean, Michael Marmot's work is absolutely crystal clear that effectively the determinants of health and well-being go much more broadly than just focusing on health. They're actually determined by issues such as, are individuals in secure employment? What's the quality of their housing? I mean, Stephen tells a great anecdote that he had the NHS Confederation conference. The chief executive of New York Medicare, I think it was, came over, and he said the single biggest intervention that had improved health outcomes in New York was the installation of air conditioning units in low-cost housing, where effectively, because in the summer spike in the heat, there were a whole load of people who were getting ill because they had inadequate housing and air conditioning in those houses. So I think there's a real opportunity here, as Stephen is saying, to actually look at place health in its appropriate set of wider determinants. And if you look at, for example, Salford, which is developing, Salford Royal Acute Hospital Trust, which is developing a much closer relationship with its local authority, and it's having a conversation not just about, yes, we're very happy to take on social care, but looking actually about how it can relate much more closely to the housing department, the leisure department, the education department, so that we can put health in this much broader set of determinants. And because the reality is, it seems to us, we've got a national illness service. We don't have a national health and well-being service where we are using the full range of public services to support people to have healthy, independent lives for as long as possible. And all the money and all the emphasis and all the management bandwidth and the capacity and the capabilities seems to us to be very largely focused on treating people who are ill, whereas, as Wanless showed 15 years ago, we're not going to be able to cope with that demand unless we actually focus much more effectively on not just prevention, not just health promotion, but putting health in that much broader range of public services.
And I would completely concur, but also add that because of the restrictions in funding and the drops in funding that everybody's familiar with, then a lot of the funding that we do have now is focused on that acuity end. So it's all about sorting out today's crisis. It isn't about sorting out tomorrow's solutions. And so if anecdotes are acceptable, then one of the things that we see very regularly on every acute ward is a point at which a patient has been admitted and gets to that stage of realisation that their isolation, their lack of independence, their loneliness and their miserable housing means that they actually don't want to go home. Their family have got to a point when they don't know how to look after them anymore. And you get a desperation point when then people make poor choices. Instead of us thinking, right, how can we get this person home? Look after the carers, their personal carers, not their pay carers, although they have a role too, but actually keep that family together in an extended way if possible and give them things that are actually quite small and relatively inexpensive, but will stop them using the A&E front door, which is, has been, as Sir Keogh would say, its own success in that it's always open, and therefore that's where people go when they don't really know what else to do, but it isn't the right place.
Can I just support the narrative with some specific statistics of the balance of spending within the health and care system? Between 2005 and 2015, a 10-year period, NHS spending in total went up 25% in real terms. Social care spending flatlined. Primary care spending went up 3.5% in real terms. Spending in the acute sector went up 31% in real terms. So the evidence is clear that despite ministerial rhetoric, I've been responsible for it myself, and I see some faces around the committee that have also been responsible for it. We've all said how important it is to challenge resources into the community, into primary care. Actually, what's happened is that it's gone to the acute sector, not to the place where ministers say quite rightly it needs to go.
Okay. Lord Warner and Baroness Redford, and then I'll go to Baroness Redford's question.
I mean, Stephen, you made a very helpful comment at the beginning about the proportion of GDP realistically being estimated now and updated. But within that sum, I would suggest that there has been huge variation year on year over time between what actually goes into the NHS, and certainly at the beginning of the year, what they can expect to spend in that 12 months further forward. And as you rightly pointed out, there's been huge variation. There's been no synchronisation between the uprating of health NHS expenditure and social care expenditure. So what do you think we should be saying as a committee about what more should be done to actually synchronise those over time, so that we don't have this random system of uprating year on year? And it's a guesstimate on the part of managers in both these systems as to how much they're going to get next year, particularly if you want to go down the path of the STP model. So what are your ideas for synchronising those spending patterns over time?
Before you answer, can I say that your comments and questioning have produce a lot of excitement. So I have a whole series of people.
It's not good news.
Before we even get on to the second question of another 6 questions. So can we have a quick fire response and quick fire question session before we move on to the next one? So please, go ahead.
Briefly, my Lord, the committee will know that I proposed, together with Alan Milburn and Norman Lamb, at the beginning of this year, that there should be a commission that looked at some of the issues your committee is looking at, precisely in order to provide a context, a longer-term context, to address the issues Lord Warner mentions. I emphasise none of the three of us thought this was to take the health sector out of politics. The health sector is intrinsic to politics in a democratic society, but it was to try to provide some of the longer-term context so that the different funding flows coming into the sector. Incidentally, it's worth drawing out to the committee that piece of work that Lord Warner referred to made it clear this is 10% of all economic activity in the UK, but only 80%, only 80% of the funding for it comes from the taxpayer. So it's not exclusively a taxpayer issue.
So if I can go quickly with Baroness Redfern, then Baroness Blackstone, then Lord Mulvaney and Lord Bradley, and Lord McCall.
Right, okay. Two very quick questions. If I could ask Stephen, please. You mentioned devolution, STPs. What are your views if the STPs are not coterminous with a devolution deal? Because I think it's vitally important that people in that area know their base subject. I would say that as leader of a local authority, and I have views on health and social care. And the second one to Margaret is disability. Only 44%, I think, have health checks. We debated that last night in the House. And how could we get more GPs to support increasing those health checks, and then therefore they can get a personal plan and they can move on?
I think the short answer to Baroness Redfern's first question is simple. It is that clearly I referred to the fact that STPs are a process being built in flight. I've already said in Birmingham and Solihull, that I don't think it's appropriate for an outsider to be chair of this board, and I propose to, I hope, sign off my report to the proper governance processes tomorrow. What there then needs to be is governance that allows decisions to be made, which clearly isn't the current state of the STP process. But having said that, I think I give significant credit, actually, to NHS England for having initiated the process of ensuring that the NHS is part of that broader devolution agenda. It clearly needs to be, and the boundaries issue needs to be addressed. But if we argue about boundaries, we shall never get any work done at all. So it's a process, not an event.
Anybody else have any quick fire response to add to?
I would suggest that there are parts where we've made some good progress here, particularly people who learn disabilities, whose health check level has gone up, diagnosis of dementia, which is vastly improved, and it's learning from those. But it's also trying to have a relationship with primary care that says the health check is more than about whether this person's physical condition has deteriorated or not. It's about how are they employing themselves in their daily life, what are they contributing to it. So I think it's about trying to make it more rounded than just the diagnostics, and then it's of much greater value to the individual person, service user and their family.
Comes for them.
Yeah.
Lady Blackstone.
I just want to follow on from what Norman was saying about the need for more synchronised spending, which follows from the figures that you were giving Stephen. And I just wonder if we're going to have the sort of integrated social policy that you're proposing, whether we can continue with a system where local authorities are quite separate from NHS institutions and organisations, and whether we shouldn't think very radically about this and consider whether, in order to achieve this, we go back to a single form of governance via local authorities, and that local authorities, rather as was proposed not that long ago by the then Chancellor, when he was trying to develop ideas about the Northern Powerhouse in Manchester, that there should be proper devolution of health to either regional or local government, and only then will we get some sensible decisions made about how funding should be allocated, and more joined-up thinking about the relationship between education, social care, health, housing, etc.
My answer to that, if I was pushed for a one-word answer, would be yes. But if I may enlarge on it a little bit, the debate between central and local is as old as the NHS itself. Indeed, it goes back before the NHS into the cabinet minutes before the NHS itself, the legislation came forward. My very strong view is, first of all, that there is a role for the N in the NHS, an important role in standards, in defining standards, ensuring that it's a transparent service, that you can see what's being delivered in one part of the country by comparison with another, looking at sharing resources, in particular in specialised areas. So there's definitely a role for the N, but the balance has gone far too far in favour of the N and away from the local. And that's not only has that created unnecessary and deeply damaging fissures within local public services, it's also reduced the accountability of the health service to local communities. And it was an argument I remember having with Ken Clarke in 1990 when we first introduced the purchaser-provider split, commissioner-provider as it now is. I was in favour then, as he was, of removing councillors from trust boards on the grounds these were enterprises that just needed to be managed as professional, as well as possible. He was also in favour, and the legislation reflected this, removing councillors from the commissioning side of what we would now call the commissioning side of the health service. I argued with him then that that was wrong. I still think I was right then, and that policy is being put into reverse in this respect, and I think that's a good thing.
Good to see that your clarity of thought and expression hasn't decreased with the passage of time.
It's kind of you.
That was an excellent summary of public service, where you took 6-8 different things and rolled them all into one entity. The budget for public service would be astronomical, but my question, as I'm being hurried on by the chairman, is how do you think we should write a report that persuades the government, which operates on the basis of 20 silos, roughly, to forget about siloing health and social care and put them all into one ginormous economic entity called public service?
Well, I don't think we're talking about, if you put health and social care together, it's not a massive increase in terms of the budget. So again, Stephen, you'll have the figures probably better than I do, but we're talking about £110 billion NHS budget, and we're then talking about, okay, so we were not necessarily saying that you would lump all of those single budgets in a single place. Okay, you say that.
I'm just quoting Mr. Dorrell.
Yeah, let me answer Lord Mawhinney, because I absolutely do not think that it follows from what I was arguing that there should be one organisation delivering housing services, education services, hospital services. The reductio ad absurdum of that, which is the anecdote that I tell in Birmingham, is this does not mean that University Hospitals Birmingham runs the primary schools in Smethwick. That is balmy. What it does actually is illustrate that this is not about changing the boundaries of managing the acute hospitals or the primary care system or the school system. This is about creating a commissioning process that looks across the range of public services and insists that there are proper digital exchanges of information, there are proper professional exchanges, proper resource exchanges. And to Lord Mawhinney's question, what's the key argument to the Treasury short of money to justify this? The Treasury is interested in efficiency. And we endlessly hear how the health service could be made more efficient, and nobody disagrees with that. And we usually hear about agency staffing ratios, and we hear about procurement, and every health minister in the room will have made speeches about both subjects. But anyone who looks at any sector, health and care is just like any other sector in the economy. This is a sector of the economy we're talking about. And how do you create transformative efficiencies in an economy? It's by rethinking what it is you're trying to do. We're no longer trying to deal with a world where people where the communication is paper-based and people present with a condition for diagnosis, treatment and cure. We're dealing with a range of services where success relies on a joined-up service to the citizen. And if that's the exam question, let's start with the right question. We'll have a greater chance of delivering the right answer.
But I think it's also important not to forget Lord Warner's point, which is there is a degree of frustration, I think, in the present government about the inability of the members who we represent to deliver the efficiencies that are being asked for. One of the problems is that effectively there is no credible medium-term financial strategy for the NHS. We've got a year this year, which is the year of plenty, where we have a 3.7% increase, which just about keeps up with demand and cost. When we all saw the settlement last year, we said, how on earth is the NHS meant to deal with a year in which funding increases by 1.4% next year, 0.3% the year after that, and 0.7% the year after that? It becomes incredibly difficult to run the system effectively when you do not have an evenness and a consistency and a smoothness of funding increase, but also a funding increase that reflects the underlying cost and demand. As one of your former colleagues, Lord Lansley, said to our annual lecture about 3 or 4 weeks ago, everybody knew that we were due a 5-year squeeze between 2010 and 2015. Nobody expected we were going to have a second 5-year squeeze between 2015 and 2020. And my argument to you would be that the unevenness of having gone, a front-loaded year, but then years that, to be frank, are miles off in terms of the increase that's needed to keep up with demand, makes it much, much more difficult for our managers to basically run their hospitals, community mental health and ambulance services effectively because of the unevenness with which that funding increases are flowing.
Okay. Now, quick fire, Lord Bradley and Lord McCall. I need to move on.
To declare my interest in non-executive director of Penang Care, and perhaps I should also declare I live in Manchester because that's relevant to the conversation we've been having. I mean, just looking at the DEVO-MANC, it is about setting that joint commissioning arrangements across place and people. And crucial to that, in my view, is, as a first step, the recognition that you're trying to integrate physical and mental health into one commissioning arrangement. Now, one of the problems, I absolutely support everything you've said, Stephen, and the STPs are a mechanism for that change. But the problem, as Chris has identified, is in the short term, because of the financial situation, it's more sustainability that those plans are looking at rather than transformation. So how do we shift to have that long-term sustainability, the funding into transformation that isn't being absorbed into ensuring current services are maintained across health and social care, physical and mental health?
I think that that's a challenge for any manager at any time in any economic sector, is the truth. And it's a particular challenge in the health and care sector at the moment. The figures Chris was quoting for the spending profile in health, in the NHS budget narrowly defined, is true in spades, incidentally, in social care, where there's significant resource planned for the last 2 years of the spending plan, 1920. And 2021. But in the short term, there's actually a further reduction planned, a significant further reduction planned in social care. This is the sector that the CQC last week described as being at a tipping point, or approaching a tipping point. And so the Lord Bradley's point is very well made when looking at the health and care sector as a whole. I think that there are 2 levels of answer. First, to Lord Mawini's point, efficiency. It is not efficient to use an acute sector, an acute hospital, as a care home, which is the practical result of the world that we're creating. So, bringing forward some of the funding that's planned for social care at the end of the spending profile, I think, is an immediate fix that could certainly create some headroom for the kind of change Lord Bradley is looking for. I also think that the health and care sector as a whole, while it will be for in the lifetime of every person in this room and of our children and grandchildren, I hope, largely a public sector provided service, a good commissioner of public services applies Lord Adebowale's principle that a public service is a service to the public. And as a commissioner of services to the public, the key question is to how you bring parties to the table that are able to facilitate the type of change that Lord Bradley quite rightly says is needed.
Okay, can I move? I'm sorry to move. I need to move because I'm managing this session in time extremely badly because we've not moved past the first question. So, Lord McCall, quick question from you, and then we move.
Wilcox, you mentioned all the causes of the increasing expenditure in the NHS, but you didn't mention probably one of the greatest, which is the obesity epidemic.
Absolutely.
And what do you have any figures on exactly how much this grotesque increase is costing?
I haven't, but we can get them. I think they may have been in the original evidence that's submitted, but we can certainly look at that. I mean, from a practical point of view, then it goes back to the previous argument that I think one of the concerns I have, or we have, and as Stephen has mentioned, is that if we only concentrate on the acute end of when the obesity crisis is here or when the person has had a fall and they're in that sort of crisis when they're elderly, then we're looking at it from the wrong end. And the answers to obesity from all the public health arguments that we've seen are about people's lifestyles, are about the social bits, they're about education, they're about good learning, they're about exercise, and they're about our children. And the young people of this country, to be able to get them to take some responsibility for themselves, but to do it in a way that's also enjoyable and that's sustainable, rather than a quick fix. And one of the things I would add about the integration of funding, whether at commissioning or at any other point, is that if we concentrate the funding on the acute end, then we will never treat the problems that we're building up. We do need to have to come much further forward into how do we deal with the prevention end of it. And we know from history that whenever finances are tight, it's prevention that goes first, because we have to make the quick fixes for the acute situation. So I think it is about trying to redefine it, and it is about moving away from a medical model and a medical solution to everything when there are alternatives.
So if you do have those figures, we'll be pleased to have them.
Yes, certainly.
Now can we move on to the next? A lot of the issues that were coming for the other questions have been covered. So hopefully we can keep the questions as subsidiaries to the original one and be quick fire response, because I got a lot of material to cover. So Baroness Redford, can I start with you?
Chairman, and my question really has been nearly answered as such, but I do agree with the panel. Funding acute beds, as a residential bed is not the best place to spend scarce resources as such. And I'm really interested in, as I say, the health and social care end. And if additional funding after 2020, where would you see that funding being targeted?
Well, so if you were taking a short-term view, I think one of the interesting things at the moment is the entire NHS but it seems to believe that if you were going to put more money in, it should go into social care, which I think is a very interesting statement in itself.
But in the past, more's been gone to the acute sector, hasn't it?
Correct, and I think we kind of identify that if you want to sort out the issues that, for example, acute hospitals are currently dealing with, actually probably the best place to spend the money is in social care to ensure that we don't have 30% of people on older people's wards occupying beds, that actually they're better off in care being provided close to home because they are medically fit to discharge. But also, again, I think Stephen's pointed out primary care in terms of if you look at what's currently happening, 6% increase in demand coming into A&E in the first quarter of this year, both in terms of presentations but also admissions. That's a function partly of the fact that primary care is completely overwhelmed and is unable to cope. There is an illustration, it seems to me, of a kind of wider point here, which effectively is we spend a lot of time talking about the need to transform the system, and we tend to talk about the money. The bit that we don't tend to talk about is that actually, if you want the system to transform, we have to incentivise our leadership teams to focus on transformation. And if you ask our members what they are most incentivised to do, you effectively lose your job as a chief executive or as a chair if you can't make today's money work, if you can't pass today's CQC inspection, if you can't ensure that you're meeting your 95% 4-hour target, if you can't ensure that you are providing the right quality of service, all of which are very important. No chief executive or leadership team has ever lost their job by failing to come up with a long-term transformation on their local health and social care economy. So one of the arguments I'd be making to you is that actually if you want the system to transform, we have to get a much better balance between the focus on today's performance targets and today's money, and actually balance it appropriately in a way that we do in most other systems, but not in the NHS because of the operational pressure it's under, and actually say to management teams, we want long-term transformation to be something that you focus on. Because all we're doing at the moment is running faster and faster and harder inside a broken model, and one day we will wake up and realise that actually we've not spent the time, the management time, and the capacity on moving towards a transformed system. And that's where I think we are, partly, to be frank, because of the pressure that the existing system is under. All our members say they are spending their whole time just trying to prop up this increasingly fragile system, and they simply don't have the management capacity or bandwidth to do the really complicated bit of bringing everybody together in their local health and social care economy and plotting a path to a sustainable future. And one of the reasons for that is for perfectly understandable reasons. They have spent their whole time being measured against today's targets, not against how well are you doing to deliver the transformation.
Can I just add to that in terms of, I think one of the things that we would ask in respect of the finances, but also in the way that the STPs work and everything, that we're trusted with the money, and local government has demonstrated it can make the cuts that it needed to be able to bring local government into some form of balance, and to always passport money through another route to us, as has been demonstrated by the Better Care Fund, is not the greatest confidence builder if you're working in local government, because we know how to prioritise things. We understand how the impact of, as I said before, things like housing and employment and equipment can transform people's just daily living and make such a difference to the level of demand that they put on other services. But we needed to be trusted to do it.
Can I just add a point, my Lord, here, which is to say I absolutely agree with both what Chris and Margaret have said, and to link incidentally what they both said to the STP process, because that's exactly the issue the STP process is supposed to be trying to address, to encourage people to think in a slightly longer term. But I've already mentioned his name once. Let me mention it again. When Sir Howard if Sir Howard Bernstein were sat in this chair now, and he was asked, how do you achieve the kind of transformation that we're looking for? When he makes his presentations on this, always starts not by talking about the deficits in the hospital service. He starts by talking about employment and livable cities, green spaces, so that people actually have a fulfilling life. The great mistake in the health and care world is to imagine that demand is a given and then to reduce it to money. Actually, demand is people's healthy living. And if they have employment, then Lord Bradley made the point that there's a direct link between mental health and physical health. There's libraries of evidence that demonstrates that demand for physical health services, roughly 20% of it, can be traced to mental health causes. Mental health caused by isolation, caused by all the social conditions we're concerned about. So we shouldn't imagine that the rest of local government is somehow divorced from and different from and unrelated to the hospital deficit. Actually, the failure to deliver those services and to deliver a joined-up version of local government is one of the key underlying causes of the hospital deficit.
Lord Mavini.
I very much appreciated Mr. Hobson's analysis. I thought it was spot on. You stopped at exactly the wrong time. Because you got the transformation and then you just left us hanging on a branch.
Yep.
If you want to do serious reform of health and personal social services, question, do you continue to leave it with local authorities but not ring-fenced so that they can actually decide how to spend the money however they want to spend the money? Or do you wrap it up with the NHS into a new body? Or do you set up a special health and social services, personal social services commission, which works in parallel? All of those would be transformational. So could you give us the second paragraph of what you said earlier?
So I think what we're trying to do in the NHS is achieve this process through the sustainability and transformation plans that Stephen has already talked about. So yes, you could try and do a top-level structural reorganisation. My kind of sense is that the NHS does not have a particularly strong history of effectively moving around organisational blocks. I think this has to be a bottom-up process where effectively you get different workforces, different leadership teams who are currently separate, a local authority chief executive. So the places where I could tell you 5 or 6 places where I think this is really beginning to work, and there's a single thing that underlies all of them, which is the local authority chief executive has sat down with the hospital chief executive, has sat down with the leaders of the local GPs, has sat down with the accountable officer of the clinical commissioning group, and they have hammered out between them an agreement about how they are going to do things differently, and they're going to completely ignore all of the stuff raining down on top of them from NHS England, NHS Improvement and everywhere else, and they're going to say, we're going to do the right thing for our local population. So the key for me, I don't think is necessarily a structural reorganisation. It's actually about local people, local leaders working together effectively to do the right thing for their local populations. And that is what is happening in Manchester, that is what is happening in Yeovil, that's what's happening in Northumbria, and it's being achieved without a primary legislation to create brand new structures. It's bubbling up from underneath, encouraged and supported from above, not mandated from above in a structural reorganisation, would be my answer.
So the GPs talk to me about being forced into new GP structures with 30,000 people and all the rest of it, and how concerned they are for their patients. All of that's just going to pass in the night. It's not going to be a factor that anybody needs to worry about.
No, I think we would all, if you said to us, where are the tensions likely to be, one of them clearly is in a primary care structure that in some places still feels like it's a 1948 created cottage industry. What I would observe is that in places like Birmingham, in places like Salford, we are seeing the growth of GP federations where GPs are willing to kind of come together to create organisations of a critical mass that are then capable of interacting effectively with these much larger organisations like mental health and acute hospital.
So are you saying that the current model of primary care needs to be changed?
What I'm saying is there's a widespread agreement that effectively the 1948 bequeathed structure of a bunch of single-handed practices led by individual GPs is unable to provide the kind and scale of primary care that we now need, and there is a rapidly growing development where effectively people are coming together in GP federations which make it easier and more effective to then link up all of these different bits of health and social care.
Lord Warner.
There seems to be a general agreement that we should do more direction of money towards social care if there was more money to be redirected. Can you tell us something about how you would redirect? What are the processes how you would redirect money from the centre to achieve that objective? Well, because at the end of the day, bottom up is fine, but at the end of the day, money flows down from the centre.
So the immediate answer is in the submission that we've just made to the Treasury about the autumn statement, where effectively what we've said is that already laid out in the government's plans are 2 ways of increasing money to go into social care. The first effectively is a backloaded increase in money in the Better Care Fund, where actually this time the government's going to put some money into the Better Care Fund. And the second is enabling local authorities to raise more through the precept, taking away the 2% cap and raising it to 4%. Our argument in the autumn statement is that both of those should be brought forward. What's really particularly important is the combination of the two, because we know that the precept effectively is potentially discriminatory on the grounds that effectively there are local authorities with lower tax bases which will not be able to raise as much money through the precept. So if you're a relatively less well-off northern council, like a Gateshead, for example, you will not be able to raise as much through a 4% precept as you would if you were leafy Surrey. Hence the need, in our view, to balance the increase in the precept with the opportunity to cross-subsidise using a better care fund that is there made to make up the gap.
But that is a short-term fix.
I accept that's a short-term fix.
So we're dealing with up to 2030. How do we get this system changed? What should we be saying in our report to get this system changed for the next 15 years?
Well, so
that's all of you.
Well,
I had heard Lord Warner's question as directed at the short term, and I agree with what Chris said, in particular about the Better Care Fund. It seems to me that's money that the government has committed to social care. It's in the budget for 1920-21, and it's actually necessary, as the CQC was arguing last week. I think that the broader question, as Lord Mawhinney was referring to earlier, of how this joined-up version of public services is to be financed is fundamentally that comes down to a question of financing local government and the relationship to Lord Mawhinney's second question, the relationship between local government and the NHS central budget, because I don't think anybody's suggesting that there won't continue to be a nationally voted parliamentary vote to the NHS. The question is the relationship between the NHS Central Commissioning Authority and the local commissioners of service within a place. If we're looking beyond 2020, I think there is absolutely no escape, nor do I look for one, from the point with which I started in response to Lord Patel's initial question for an opening statement, which is that health and care services are a growing part of the economy. And if we manage public finance, seek to manage the structure of public policy or public finance, to restrict the growth of the public sector for all the reasons as a lifelong Conservative I'm fully familiar with, we have to reconcile the ambition for manageable tax burden, small state and all of that. We have to reconcile that with an explicit commitment to allow the health and care sector to grow in a way that reflects the ambitions of the society it's there to serve.
And I think if you're right, Stephen, it seems to me what's fundamental is that if you're going to increase funding in a taxpayer-funded system, you have to have a quality of debate with the taxpayers where you are effectively setting out the options for them about what the consequences of, for example, carrying on with flat funding or reduced funding, and what the consequences and the benefits potentially are of increasing those funding levels through increased taxation. So I did an interview for ITN last night. They'd done a poll where effectively they've said that 70% of people interviewed would be prepared to see 1p extra on income tax. 50% would be prepared to see 2p extra on income tax. My argument would be that in a taxpayer-funded system, if we're to have the kind of debate that Stephen is talking about, whereby we're saying we are going to increase public funding, you will only do that by building public consent. And I have to say, I do not see a quality of public debate at the moment that actually enables us to have that proper discussion and to gain that consent. And it seems to me it's urgent that we find a way of having that proper debate with an appropriate level of underpinning evidence to actually enable, an informed debate rather than the sort of quality of debate we had in the general election, which tends to revolve around things like wars of Jennifer's ear and stuff like that, as opposed to the real fundamentals that underlie this.
We really do appreciate the precept, and as you know, a big percentage of councils took it up. But there is an irony about it in that if you have a high level of self-funders in your particular local authority and you're more likely to raise the precept, you're also less likely to have the need that some of the areas where the precept is very difficult to get in because there are lots of people below that threshold and their level of need would be the same. Clearly the north-south divided is an example, but in between particular councils as well. And there are perceptions that this is a local tax and therefore local people are paying for what they can locally afford, as opposed to having a national scheme for everybody to meet a level of eligibility criteria and service. So I think there's a balance to be had between having a local tax and saying, actually, this is the level of qualification that we want for the country, and this is what you should expect to pay in return for your major taxation.
I think this discussion leads very well to your question, Lord McCall, about funding issues.
If more money is not forthcoming, what exactly should be done? Should alternative types of funding, such as charging for some services, encouraging greater private spending, limiting on what the NHS provides, should those be considered? And what alternative funding models do you consider to be viable alternatives to the present arrangements?
Can I link that to Margaret's last answer? Because I think that there's an important point that is quite often lost in the discussion of funding and health and care. The government quite rightly says that it's committed over the lifetime of this Parliament to additional spending of either 8 or 10 billion pounds, depending on your point of view. What it doesn't then do is to add the yield of the precept as additional funding, because actually by opening the precept as funding available to the health and care sector, what the government did was to unlock a significant level of additional funding, which in our view should be brought, the access to it should be brought forward through the Better Care Fund. But so there is in a sector where, as I've already said, it's 180 billion pounds we're talking about, of which the total taxpayer contribution is about 139 billion. There's roughly 40 billion pounds already comes from other sources into this single sector. So getting beyond the debate about the NHS to a debate about health and care, and preferably to public service more generally, gets you into a world where there are already more than one funding stream. And the question is how you secure the objective of equitable access to high-quality services without changing the free offer of the health service, but in the context of a broadly funded public sector with sufficient resource to deliver the outcomes we've been talking about.
Do you want to increase the 40 billion from other sources?
Well, I think it would be a very odd way of dealing with consumers if we didn't look for ways of, given that the whole basis of my argument is that as societies get richer, individuals, all of us as citizens, choose to spend, want to spend more on the services delivered by the health and care sector. We should be looking for ways of accessing alternative, the widest possible revenue sources without changing the free offer. Where the question that Lord McCall is hinting at is, should we go in for a revised funding basis of core NHS? My answer to that is no. It's a question for Parliament, not for NHS managers. But my answer to that is no, because actually it misses the point. The point is this sector already has diverse funding streams, and what we're doing at the moment is relying unnecessarily on the tax-funded core because we haven't set up a structure that attracts sufficient funding into the broader into the sector more broadly defined.
I think I accept that, quite rightly we're talking about the wider health and care sector, but I think, you would expect me to bring an NHS-specific and an NHS provider-specific focus on this. And I think we've gone on the record very clearly about 4 or 5 weeks ago to say we think we have now reached a tipping point where effectively the NHS is being asked to deliver a set of services that it simply cannot carry on delivering for the funding available. And we would make the observation that, yes, it's perfectly understandable that the Prime Minister and the new Chancellor should be saying to the NHS, you've got the best settlement of public services, you've effectively had extra funding, go and deliver. The reality is what's happened to most other public services faced with similar pressures in terms of, yes, we have had more money, but the demand that we're experiencing is much greater. In all the other public services, what's effectively happened is staff numbers have been reduced. We've had 450,000 people who are no longer eligible for social care because the social care eligibility criteria have been changed. Bins are now being collected once a fortnight rather than once a week. Libraries are closing. The key point we are trying to make to the government at the moment is that the NHS is unable to adopt any of those strategies that have been adopted by other public services because we have an NHS constitution that specifies what the performance standards should be, that specifies what the targets in terms of 4-hour waits in A&E should be, and that effectively has a bunch of recommended staff ratios that are enforced by a very rigorous inspection regime. So what our members are saying very clearly is you can't have your cake and eat it. What you cannot do is expect the NHS to increase, deal with 4%, 5% increased demand every year, but only increase the funding by 1%, and then not allow us the service flexibility that other public services have had to change the offer, reduce the change eligibility criteria, or reduce staff numbers. And so the NHS has reached this point where it cannot carry on meeting those formal criteria on the funding available.
Particularly, if I may emphasise the point, when the effect of many of those other changes in other public services is to divert demand into the NHS.
And also to distract the people that we rely on, such as the informal carers. Because actually, if we had a better offer for informal carers, then we would have a broader capacity of workforce that's available to us. Because that's the other thing that we've spoken very little about today, but the future workforce across health and social care is seriously under pressure because we're all fishing in the same pond for staff. The status of the voluntary sector carers has dropped dramatically. The public doesn't have the respect for them that it used to have. And we have a retail market that is now far more attractive to what would have been the unqualified workforce now than social care can achieve, and in areas where you've got low unemployment, it's absolutely impossible to recruit to those posts. So we've got a whole sea change which is much broader than just the delivery of the acute service. It's actually how do we change the way that we run our community service, and what sort of models of expectations should you have if you want to stay at home. Who do you think should be coming through that door to look after you, and how should they do that? I think the days of having routine 4 visits a day of 4 different people is not what the public expects, and it hasn't been satisfactory, and to a certain extent some of that has led to the need for acute care when people lose confidence in being able to manage for themselves at home, and they get frightened.
Lord Bishop of Carlisle.
I think from what you've all consistently said, your answer to what I'm about to ask is fairly predictable. But I'd like to pick up on this issue of tipping points. It's an expression which has been used more than once in the conversation. And I'd like to focus the question around the recommendations of the Dilnot Commission. As we all know, the recommendations have been deferred, or the implementation of them deferred until 2020. And the question is really, do you think if that happens and they're not implemented sooner, as seems likely, that actually we will have reached a tipping point and the implications for the long-term sustainability of health and social care will be severely damaged?
My view of the Dilnot recommendations is that they ask the right question, which is actually was the one we touched on in the earlier answer, how you get more private funding into the delivery and a more broadly funded service. I'm not entirely convinced that the Dilnot recommendations achieve the objective of more private funding. And they certainly have the effect of targeting taxpayer funding at people who probably wouldn't be at the highest end of the urgency list if we're dealing with urgent pressures in the system. So I think that the Dilnot process probably needs to be rethought, but I think they were addressing precisely the right questions.
Thank you very much.
And I think we were hopeful that if by deferring it we would have had access to the 6 billion that was allocated for that, we could at least in this particular time have tested out what those opportunities would have been and maybe be able to find some solutions, because some of the figures from an ADAS point of view still look a bit understated in terms of the actual volume for the future. But we would have had a longer lead-in time to be able to know what it is. And of course, the longer it's left before we know, is it going to come in 2020, in terms of the change, the implementation of the legislation, not in respect to the money, because we're still optimistic that some of that may come forward, then the longer it is before we can test out those issues that we still don't know whether that's the case or not.
I think what's particularly worrying as well is that since the DILNOT proposals were put forward, it seems to us that the social care market has become and sector has become even more fragile. So in other words, effectively what's happened is, for example, the funding gap has grown. But I just point to one other thing, which is that one of the things that, I think the CQC pointed to and that we are very concerned about is the number of private providers who are basically saying they are struggling to see this as a viable proposition. And if you look at the number of both big organisations but actually even medium and small sized organisations that are withdrawing from the market because they are no longer able to provide, to earn a sensible commercial return out of it, then effectively I think you could see, even if we were to kind of do DILNOT Mark II quickly, actually I still think that some of those underlying market factors have actually fundamentally changed and worsened, making things even more difficult than they were when DILNOT was making his report.
Thank you. And is anybody actually looking at a revision of the DILNOT proposals? Do you know?
I don't know at a national level. I certainly know because I work in the southwest, that Bournemouth University have done some very interesting work at looking at the predictive figures, and certainly ADAS will be picking those up in the new year because we want to explore. And if my memory was good enough, I'd be able to tell you who it was, and he just shot out over there. But they've certainly done some work on it, and I think are coming up with slightly different calculations.
But without more money in the near future, we've got real problems.
And we've got the issue, as CQC pointed out in their report, that we know that small organisations in private care have better quality as a generalisation. Some of the big ones do too, but those small local organisations do very good services for their local community, and they're the least likely to survive in the current climate because they're just too near the margins of being sustainable for them. And that's a great loss, because we don't want everybody to be treated the same. We want a local flavour for what at the end of the day is community care and not institutional care.
Thank you.
Lord Lipsey, then Lady Blackstone.
I just wanted to make a clarification on DILNOT there, which Norman Warner knows very well about. DILNOT made one set of recommendations. They were not adopted by the government. The government adopted one with a much higher threshold, and those are what have been postponed, obviously having much lower costs than the DILNOT proposals. I think we ought to be absolutely clear about that.
Thank you. Baroness Blackstone.
I'd like to turn to the question of the very big variations that exist in the social care services in particular. And I wonder whether you've got any suggestions as to how to deal with these variations.
I mean, my answer to that would be to emphasise the importance of national visibility on the experience of citizens in need of social care. And I think that it's often said that as an over-centralised, I've already said, as an over-centralised service, the National Health Service is supposed to deliver the same to everybody, and increasingly it's anyone who's ever worked in it knows perfectly well that isn't true. And increased transparency of patient experience within the NHS is making it more obvious that that is not true, and that's, in my view, a good thing, because it focuses attention on where variation does occur. And I think exactly the same principle should apply across the range of public services, actually, not just specifically in social care, but across the range of public services, so that the kind of, use the jargon, the place-based services that we've been describing this morning, actually can see both the experience of quality of service delivered to a community and, ultimately, much more importantly, the outcome achieved for the residents of an area, because the thing that really matters is the measures of life expectancy, of morbidity, of the way in which people lead their lives. And all of this debate is so often, as we inevitably have been this morning, about funding mechanisms and structures, not about the difference of citizen experience as compared in East London and West London, London and Berkshire and Northumberland and so forth. And if there was more visibility and discussion about that we would have more genuinely accountable public services.
I think also that there's an issue about certainty. I think because the market is so uncertain about where it's going, so it's uncertain about its migrant workforce, it's uncertain about future pay structures, it's uncertain about the types of qualifications that will be available to people and how we develop new models of care. It's uncertain about the future of the strength of the GP workforce because they're clearly not coming forward. It's not the career it used to be, and therefore there's a new model there. And it's certain about the future funding for either through local government, through social services, or indeed from self-funders. And therefore, the growth in that market that we saw 20, 30 years ago has completely subsided. And then you get the geographical variation, which I've already alluded to, which is where richer communities will have more sustainable services, has a greater demand for them, it's easier to create them, whereas areas with greater poverty has fewer self-funders, has local levels of government funding which is lower than its neighbours, and therefore to a certain extent, has a lower expectation as well amongst that community because it's not something it's familiar with, and therefore the aspiration needs to be built. And I think that unless we have a period of certainty, that it is very difficult to want to reassure people that this is a business they want to be in.
I think we should also be honest with you, which effectively is, you took an NHS perspective, there is no doubt there is, and again you know this because you have been very involved with an NHS provider, there is excessive unwarranted variation between individual trusts and foundation trusts, and the Carter Review has absolutely shown that in terms of a number of different variables in terms of clinical outcomes, in terms of procurement efficiency. The observation when I talk to our members about it, about okay, so this variation clearly exists, do you accept the argument? Everybody accepts that variation exists. And I hope you won't think this too feeble, but effectively what the conversation then goes on, that what managers and leadership teams say to us is that in order to get to that variation, you need a quality of data, you need a really difficult and challenging debate, often with senior clinicians. You need change management, you need project management. You actually need sufficient management bandwidth and capacity and capability to drive what is a very far-reaching and is a difficult change process. And, classic example, I was speaking to a very good chief executive of a district general hospital on the phone last week who said, I know it's there, I'm having difficulty persuading my senior clinicians about what we should do about it, but to be honest, I simply don't have enough data analytical people, change managers, project managers, and people to bring that senior clinical workforce with me. This entire leadership team has spent the last year trying to prop up the day-to-day operation. So if I could find £2 million to effectively employ a group of people to drive that change and to take the senior clinical workforce with me, I think over a 2 or 3 year period, I could probably get to that variation. But if you're asking me, can I get to it now with my existing resource and given the pressures I've got, keeping this increasingly fragile system upright? And she said, we've been counting detox, delayed transfers of care, double the amount of delayed transfers of care from last year. They therefore lost, they'd had to use elective beds, and therefore they were now in financial problem because they couldn't have elective surgery going through. She said, it's just a nightmare trying to keep this up and going. So if I'm going to really get to this complex, difficult to winkle out variation, I just don't have the bandwidth and I don't have the middle management capacity, because if I'm honest, I stripped it out when I was doing the first set of cost improvement programs between 2010 and 2015. Now I know it sounds feeble and I know it in some senses, but the reality is that is what our chief executives are telling us. They can see the variation there, they know they should be getting to it, but it is actually a very complex, difficult task, particularly the relationship with the senior clinicians, and they do not have the bandwidth or the people to be able to do it. So if we want to get to the variation with the speed and with the consistency that we would all like and with which Lord Carter would like, we have to recognise that we need to support our trust to get there and not beat them up and spend the whole time saying, why have you missed today's target? That is the reality of what it's like trying to lead in the NHS today.
Quick question. I mean, are we whistling in the dark about the social care sector? Are we not at a point where if we get to 2020 and not much changes, there won't be a publicly funded social care sector to provide the services anyway? And that seems to be the message coming out of the State of Care report by the CQC. Is it now at a tipping point where even if we start pumping in later in this decade money into this sector, there won't be any providers who trust the public sector to go on funding them to actually run this sector?
I think there's a real risk of that. That would be my view.
I don't actually agree with that. I think that the economic sectors are more flexible than that. But I think what happens is that pressures build. Spending is reduced in care homes, quality suffers, at the margin capacity is falling, it's not a prediction, it is falling, and so the pressure continues to build and the pace of the pressure builds. But Chris and I were both at my former committee in another place last week and heard the question was asked, where should money go in the system, where is it most unstable? And Chris and I were both of the view, reflecting the view of NHS England. It can't be too often that NHS England or its predecessor organisations in its history have argued for funding to be spent, extra resource for a different spending head than the NHS. In order to protect the NHS, it is necessary to stabilise social care. I think it's not right to say the sector wouldn't be there by 2020, but I think it is being damaged and the pace of damage is quickening.
Can we hear from the local authority?
Yes, I mean, I think the other area is, and it does differ geographically from parts of the country to other parts, but it's about being able to have the capacity to build up an alternative domiciliary care market, so a much broader one. So if we take the examples of personal assistance, we've had, generally speaking, quite a lot of success in getting that model to support people with physical disabilities and learning disabilities, less success with mental illness, and very little success, generally speaking, with some exceptions, for older people, because it's not something they're familiar with. Whereas we've started with younger people with the personal assistant model, and that's worked well. But, as I said, the attraction of being a domiciliary carer in the current market isn't good, and we need to build that. We need to build some career structures for them. Many of us are talking with our universities already about linking it to the associate nurse programme and the apprentice nurses and having an apprenticeship for the voluntary sector. But again, it's about building up that esteem and building a career for people that want to look after other people. We know that there are those people out there, but we can't attract them at the moment because of the instability of the market.
If there's no funding available now, the system, no matter what you're trying to do, will not be there by 2020.
I wouldn't say it wouldn't be there. It will just be under even more pressure.
Nakeka.
Well, Chairman, thank you. I should declare my interest as Chairman of University College London Partners. So, just to be absolutely clear then, a sustainable health service would not be possible without a firm and established social care system beyond 2020. But I want to just focus on the importance of the two being properly integrated. And would you agree that for there to be longer-term sustainability, the two, healthcare and social care, have to be fully integrated in a way that they're not at the moment? And do we have any evidence that the Better Care Fund is providing that type of integration in a way that is going to be sustainable in the long term? Do we have examples that it's achieving what needs to be achieved in the period between 2020 and 2030, in some early examples now, for us to have confidence that route forward is feasible? And can we be clear that local authorities are being funded at this stage, beyond funding that's going into the health service, to drive that kind of thinking in integration and allow them to be courageous enough to bring the two services together?
So my argument would be that absolutely, that in order to get a sustainable health and a sustainable NHS and a sustainable health and care system, the two systems do absolutely need to be integrated, and they need to be integrated effectively and consistently right the way across the piece. If I'm honest, I think the Better Care Fund is a complete red herring and was right from the beginning. The reality is, if we were being kind, it was actually an attempt to cover up the fact that the government was actually pulling money out of the health and care sectors. And okay, fine, finally, we have now got to a point where at the end of this Parliament, actually the government will be putting money into the Better Care Fund, but as a means of driving better health and care integration, I think it's, as I said, for me, it's actually it's mostly a red herring. What I think is happening, though, is that through social sustainability and transformation planning process and other processes, as I was describing earlier, local health and social care systems are coming together. For us, it's a very differential process. I could point to you to 4 or 5 places where it feels pretty well advanced. Often they're places where they are NHS England vanguard sites, which are deliberately designed to speed up this health and care integration. But in other places, to be frank, it's lagging a long way behind. What is clear, and the international evidence absolutely suggests this, right the way consistently across the piece, is that we seem to be able to, when we do this integration, it takes a long time. It's not 3 to 5 years, it's more like 5 to 15 years. But also, secondly, the international evidence suggests it does not produce significant numbers of extra savings. What it does do, relatively quickly it seems, is produce a better quality of patient and service user experience. The other point to just make is that when we talk about health and social care integration, it seems to me we need to understand that it's something that needs to happen on multiple different levels. It needs to happen at a national structural level. It needs to happen at a local leadership level. It needs to happen in terms of a local workforce level. It needs to happen in terms of the way that we treat funding streams. And actually, it's a very, very complex, multi-layered process in which a whole load of different things need to change. Culture is a very good example where actually we need to get past this idea of separate silos. So this is a complex process that is not going to take a short period of time. It'll take a long period of time, and in our view it will not fundamentally solve what appears to us to be a growing gap. And the one thing we haven't talked about is actually, if you look at the demand that is coming, actually demand patterns in the NHS are not going to be stable. We're about to go through, as the post-war baby boom comes up to its 70, 80, 90-year-old natural life, we're about to get a huge spike in NHS demand where we're struggling to kind of make the system work both workforce-wise and money-wise at the moment. We are wholly unprepared, in our view, to basically cope with this bulge that we know we've got coming.
So what would you say is the single most important impediment to ensuring that integration takes place effectively over the medium term?
Without doubt, the way that the system kind of currently operates, which effectively you ask our chief executives, and what they'll tell you is that they are effectively, the regulatory system is based on silos, the culture is based on silos, the way they're measured is based on silos, the way the money works is based on silos. So a very simple thing, and again I'm sure my colleagues will want to talk about this as well, is that the way that the acute sector is currently funded, acute hospitals, is by payment by results. So effectively there is an incentive, in a sense, on them to pull activity into the hospital as a means of maximising income, where actually I think most people who want to create an integrated health and social care system know you need to move to a whole population capitated budget. But in a sense, the joke that we have back in our office is that almost everything about the existing system is locking people into the existing silos, the culture, the leadership training, the performance management, the regulation, the existing governance structures. And in a sense, the people who are making most progress towards integrating health and social care at a local level are doing so despite the existing system.
I think
and
the message,
setting it all aside.
I think the message came across quite clearly that you're seriously taxed by the current system.
Yes.
Lord Bishop of Cardiff.
Just given an answer, actually, to the question I wanted to ask, but I'd be interested to know whether the others agree. We've heard various times in this committee that the integration of health and social care won't produce monetary savings, but will improve the quality of the service and care. And I just wanted to clarify that.
That was the point I wanted to pick up, actually, out of what Chris said, because everything else he said in his last answer I broadly agree with. I think there are 2 points to be made about the impact of more joined-up services, more integrated services. The first is that there are better outcomes for citizens. And the second is to be careful about this argument that there are no savings. And the reason is that there's only a saving in an acute hospital if you remove the capacity. And what actually happens when you have more joined-up services that sustain people for more fulfilling lives outside hospital is that they have a better life And actually, we don't close the capacity. What we do is use the capacity for somebody else. Yeah. And that's not the same thing as saying no savings.
And I would agree, and I think that there isn't any international evidence because that has never happened. People don't close the door behind it, they just develop something else as an alternative. I mean, I think we would say that the key to it is through commissioning collaboratively, jointly in an integrated way, because we're not just matching, in terms of provision, we're not just matching one culture in the local authority with one culture in the acute hospital or the CCG, because actually in health there are 25, 30 different cultures. Every department, as you know, has got its own way and its own thoughts of behaving, so it's a completely new culture you need to develop, not just try to mix a pot up of the existing ones. No. Otherwise you'll get one predominant feature which will destroy some of it. And it's very trite to say, but the bottom line is trust. If people trust each other and are allowed to test that trust, then that's when you can pull off.
So
really
in that context, Baroness Blackstone has a very important question for you.
Could you each say, in just a couple of sentences, what your key suggestion for change might be, which the committee could make as a recommendation to support the long-term sustainability of the health service?
So I think my view would be that we need to keep a taxpayer-funded system but increase the funding coming in which case we need to think much more carefully about how we build a national consensus around that increase in funding, which requires a much better quality of public debate about what the funding levels for the NHS should be and what the consequences of not increasing funding might be.
I think there are two elements to sustainable health and care sector. The first is to go back to the argument with which I began. There is public support for, public interest in, and a long history of those things for a growing health and care sector. And we have to convince ourselves and the public that that's something our policy structure can deliver. So it's a growing sector, and we should be, the reason I emphasise it is that we're constantly told that if you draw the graph through a straight line for umpty 9 years, it takes 100% of GDP. That is true, if you think about it, of any growing sector in the economy. And what we should be seeking to do is to facilitate the growth of this sector as part of a growing economy. And of course, we should want to deliver it efficiently in a way that reflects the needs of citizens, which is why I focus on the need for empowered local government as a key partner in that process.
And we would say, and in support of both, that there's a recognition that health and social care are inextricably linked, and they are also inextricably linked to our economy. And therefore the conversation we need to have with the public is about what do you want us to do when we're working and paying our taxes? How do you want that to work? What do you want us to do when we provide that service for our families? And what do you want us to do when we need it for ourselves?
Thank you very much. Thank you all for coming today. The most exciting session we've had. I've allowed it to way overrun. and I hope that's not going to restrict our next important session that we're going to have. So thank you very much. And if you
The proceeding is currently in private. 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 The proceeding is currently in private.
Apologies for keeping you waiting. We unfortunately got too excited about the previous. I have no doubt that's equally going to happen in this session, because you're obviously very distinguished witnesses today, and we want to explore with you key issues. So I would first of all to say we are broadcasting, so any conversation you have will be recorded. Secondly, that at the end of the session and during the week you'll be sent the record of our session. Please, if there are any pertinent correction to make, you can't add or subtract from it, but certainly you can correct it. And any additional material that you may think might be useful that may come about in the session today, please feel free to send it to us. If you wouldn't mind introducing yourself, and I'll start from my left, and who you represent, if you do, and also if you wish to make any opening statement, please feel free to do so. So can I start with you, Lynn Barker?
I'm Kate Barker. I think here I'm mostly representing myself, but I'm here because I chaired a commission for the King's Fund a couple of years ago. And in that regard, I should say that since I completed that work, I haven't really stayed in touch with this issue.
But it was a very important report, and we will do
it's very kind of you to say so. And I still think it's a very important issue, but I just wanted to say that I haven't really followed the ins and outs of the debate. I do think, of course, that we face very difficult issues here. How far as a nation we want to share the financial burden of illness and ageing is the first one. And the second one is how on earth do we deal with a huge bureaucracy like the NHS and make it efficient without losing what's so important to it? And I assume those are two questions you want to address today.
Hello, I'm Julian Forder. I direct a research unit at the University of Kent called the Personal Social Services Research Unit, and have worked now for over 20 years on social care and social care issues, and more recently looking at health and health outcomes.
Thank you.
I'm Andrew Gilmore. I'm the warden of Nuffield College in Oxford, and I was the chair of the Committee on the Funding of Care and Support back in 2010 and 11. I'm thinking about these things for many, many decades. It seems to me that the big challenge that we all face and that your committee seems to be needing to address is that in this country, as in almost all parts of the world, the demand for health care, broadly construed, including social care, rises more quickly than the economy grows. In this country, for the last 60 years, the average rate of increase of health service spending has been 1.6% a year, more rapid than the growth of the economy. And that's the challenge that we face. I don't think it's in any sense is an insuperable challenge. We spend less as a share of national income in this country on healthcare than many other comparable countries, indeed probably less than half of what's spent in the United States. So I'm not at all tolerant of those who say we can't afford anything very particular, but we do have some choices to make, and getting the public debate to engage with those choices has been a struggle.
Thank you very much. Lord Lipsey.
Thank you, Chair. Easy, medium, easy and hard question. Easy, do we need to spend more on social care? Harder, how much more? And hardest of all, how do we divide any extra we do spend between helping people, perhaps better off people, to pay for the care they receive, and between the alternative, which is spending more on services themselves?
I'm happy to have a go. The answer to the easy question, do we need to spend more, is yes. And I don't think any more needs to be said on that. We face what looks like a critical situation in social care across the country at the moment. And of course that's been said before, but it does look critical at the moment. We see things like closure of large numbers of care homes, and we have challenges like the living wage coming down the track at us. So the answer is yes. How much more? I don't think that's at all an easy question to answer. And my own view is that the answer to that depends very much on the answer to the third question: how do we split the responsibility between individuals and the community? It will come as no surprise to this committee that my view is that it is perfectly reasonable to split this between individuals and the community, and certainly the work that we did on the Care Commission, of which of course Lord Warner was a noble and distinguished member, showed that most people think it's entirely legitimate that they should pay something towards their care costs. The principal argument that we put forward was that in the split between the individual and the community, it was the catastrophic costs that should be borne by the community, and that's why we argued for a cap, and there are all kinds of arguments that can be brought forward for that. precisely where that cap should be placed is, in the end, I think, a political judgment. So the further towards the left and to the universalist position you are, the lower you would tend to argue that cap should be. The further towards a more self-responsibility, libertarian position, the higher that cap should be. But it seemed to us absolutely clear that there should be a cap. Until there is a cap, so that we take away the gross fear of disaster from individuals, we will not get a better care structure where individuals are willing to spend more of their own money and where the private sector can actually provide something that isn't always ground down towards the lowest possible level of quality.
Well, it's difficult to... I certainly agree on the first point. It is clear to me that we do need to spend more on social care, and I absolutely echo what Andrew has just said about the fact that the system looks as though it is closer to crisis probably now than it has ever been. We've seen this tremendous fall in the number of people who receive public support, and we see real pressure on care homes, and we know that even when you take the new 2% precept and the Better Care Fund, that is still hardly going to help the care system out with meeting the costs of the national living wage, which in other respects I think is a worthwhile proposition. But it will not. But it will lead to much greater pressure on care homes, and we have just had the Care Quality Commission report pointing out that care homes have not improved very much since the last time they went around, which I think is a rather sad conclusion. So we clearly do need to. I think we need to spend more, and the question is whether the more is going to come largely from the public or from the private sector. One thing which gives me a lot of cause for concern, because I think some of one's response to this is about one sense of morality, what's right. My view is that to see poorer and less and frail elderly people getting very poor quality care is something that we should be ashamed of. But the other thing I think that should give us pause for thought is when we are asking people who are paying for their care, people who pay for their care privately, who are effectively cross-subsidising other people because we don't fund those other people adequately, which means that for those individuals, they are doubly hit. One thing is that they're not well or they wouldn't be in care in the first place. And the second is that they're having to pay for themselves and a little bit of somebody else. And that, I feel that is a very profound injustice in the system. So where does the... I have to say, while I agree with Andrew that a cap is absolutely vital, I'm not sure I can... And I agree with him that people who can afford it are going to have to find some money towards their care. After all, although we talk about the NHS is free at the point of use, there are lots of things, in fact, in health that you have to pay for: teeth, prescriptions, other things. And indeed, you know, if you break your leg, the health service will mend your leg, but they won't move you from A to B when you need it to get to work. You have to sort of work out how to do that yourself. So we have to recognise that every need can't possibly be met and shouldn't be met by the public sector. But I think one of the points that, I just want to say this now, one of the points that came out, I think, of the work I did when I was at the King's Fund was that it isn't just about funding, it's about how people work their way through the system and the difficulties people have in working their way through the system and the oddities that arise within it. So a big point of the work wasn't just about what people are entitled to and how that might be funded. It was about a system that worked better for people, suggesting that when people had fairly low-level needs, they should have a small and non-means targeted benefit, that as their needs grew, it would have to be, their help became more extensive and would have to be means tested, but then at a rather lower level than today, people should be able to have more free care from the health service, and in particular from the state, and in particular trying to move away from the cliff edge that exists with regard to continuing health care, because it is truly heartbreaking to think of families who are suddenly told that their relative is a little bit better, and that's great, and now they have to pay a large bill because they've come off continuing health care, but obviously their care is still very expensive. To have that sort of difficulty in the system, so that in some ways you'd kind of quite like your relative to be a bit iller again, that also seems to me profoundly morally difficult.
So is that what you meant in your report when you suggested that the various forms of wealth taxation should be explored further?
Well, I think in terms of talking about wealth taxation here, I'm thinking clearly about inheritance tax, which is I'm aware is a deeply unpopular subject. But I remain a bit baffled by a world in which we don't want to tax people's family homes when they die, because quite rightly we know that people really want to pass on the value of their home to their children, and I want to pass on the value of my home to my children. I recognise that. It's a very natural human desire. But actually, if they need social care, the whole thing gets wiped away. That, again, feels to me uncomfortable. So I do not quite see why we wouldn't want to tax inheritance a bit more in order to enable there to be some money so that individuals who do have social care are still, may still be able to enable their children to inherit. Now, people will then say, well, that's what the cap's about. It's enabling rich people to pass things down. But of course, family housing is not just among the rich. It's pretty widely spread throughout the population.
Professor Ford, are you to the original question from Lord Lips?
Yes, certainly. Well, the two questions, of course, are intertwined. I think one way of looking at them is to consider some of the problems, and I think the two main ones are one of underconsumption in the current system and one of underinsurance. Underconsumption, I think, stems from two things: the way in which the needs threshold for eligibility has been set and recently has been increased, and so that you've seen considerably fewer people being eligible for support in the social care system, particularly older people. And the other is around the charges that people face and the disincentive effect that charges have. So I think there is underconsumption. I think those people that are below the thresholds for eligibility are likely to be in a poor situation. I say likely because we don't actually know a great deal about their situation. Those people that are still eligible, I think, do get a reasonable level of support, and I think that work can be done, and more work should be done to determine whether or not that's an appropriate level. But for those people who are not eligible, I think we really need to consider their situation. And then the underinsurance issue, I think, obviously Andrew had really tackled that issue around trying to provide insurance for people at the tail end risk. And I think those people who fall outside of the means test are in a situation where they're likely to face catastrophic costs, or they could well face catastrophic costs. And it always struck me as something you'd really want to insure against. And there is very little provision for insurance. The private market for insurance clearly doesn't work. Voluntary insurance doesn't work. It's not worked in any country. It doesn't work in the US. In fact, the few providers of voluntary insurance in the US are now passing the market. If it doesn't work in the US, it seems very unlikely it will work anywhere else. So with that market failure in mind, there seems to be an important solution for the state and some role for statutory insurance.
Lord Warner, you had
I ought to declare my interest as a member of Sir Andrew's distinguished commission. Really a question, I think, mainly for Kate Barker, but perhaps for both groups. Have you changed your views in any way since the publication of your report? Those are still the recommendations that you would like to make. But could you also say something about a situation which has occurred both since the Barker report and particularly since the Dilnot report, which is that the synchronisation between the uprating of health, NHS, and social care has got worse. It's got more out of sync, in the sense that in the real terms supplements each year for both those services is now very much out of sync. How do you think the committee should address that issue as well, given its impact on sustainability of the NHS?
Well, I admitted right, or I didn't admit, I explained right at the beginning that since I wrote the report, I haven't stayed closely in touch with the debate, which means I haven't spent a huge amount of time reflecting on whether I'd reached the same conclusions again. But when I look back, my sense is that I would reach broadly the same conclusions again, which is that, I think the point that Professor Forder has made, that there should be better entitlement to state support for people at a lower level, at a lower assessed level of needs than today. It seems you have to have quite a sort of high needs test that you have to get over to be entitled to state support. If there is anything that I have changed my mind on, and again, as echoing something Professor Forder said, it's probably about insurance. We didn't suggest insurance. I think the proposals we made, which were about tax, largely about raising a little bit more tax today from the whole of the pensioner population and their wealth, were perhaps what you need to do, because after all we have old people needing social care today, and insurance is potentially more of a solution tomorrow. I think if I were rewriting it today, I might think harder about whether in the long run we needed to have some form of insurance for social care. And I certainly think, well, I think we commented on this in the report, that the lack of understanding in the population of how the social care system works is still very significant, and we ought to do something to address that. And in terms of the variance in the public budget, yes, I absolutely agree. I've already made the point that the extra money that's gone to social care will not be sufficient to do more than offset the impacts of the national living wage. So we are facing a situation in which care beds, which we badly need, are not likely to be supplied in the right number. That will add to the pressure on the health service. At the same time, and since I think it should be part of the same budget, local authorities' ability to invest in health prevention has been affected by the cutbacks, and all that, as you rightly say, is adding to pressure on the National Health Service. But the failure to sort of think of this as a system means that we then continue to have what I found the most extraordinary feature. I know in some parts of the country people are progressing with integration, but what I found the saddest thing when I was doing the report was people who had been stuck in hospital or stuck in some other way because the health and social care system, while they felt they were entitled to something, they couldn't decide who they were entitled to it from. That's a terrible thing to happen and we have to work out a way of making that work better, not because it saves money, that's not my primary reason, but because it's fundamentally wrong that people should be left in that situation.
Well, yes, I think I think Dame Barker's report was very good and covered many of the issues. I too think that perhaps we should be moving more toward a statutory insurance model, and this question of hypothecation, which I know they looked at in detail. And I was thinking before, in preparation for this meeting, about why argue for hypothecation in social care and maybe not hypothecation in healthcare. I think that still remains a knotty issue for me, but I would say it is partly to do with two things. One is the age relationship in social care. So I think if you were to move to a hypothecated system, having some age-related elements to that would be important, and you can see examples of that in the Japanese system, for example. Their long-term care insurance has a 40-plus contribution, so people over 40 make contributions. In the German system, whilst there's no specific age threshold, it's certainly true that pensioners make contributions all the way through. Actually, families without children make differential contributions as well. So I think there is some distinction between that and the health service. I think also the role for informal care and where we are in terms of social care and long-term care coming very much from a tradition of being a family responsibility also changes the equation somewhat. So I think I would argue for some form of partial hypothecation, some form of insurance system for long-term care as a way of more closely linking the idea of people making contributions and the care that they receive.
So in the German and the Japanese system of insurance, what is the level of contribution?
So the German system, I think, is around 1.9% of income. The Japanese system is quite complicated because they have some of it comes from income tax, some of it comes from a specific earmarked contribution. But it's a quite generous system, so it would be slightly more expensive than the German system. So I think that order of magnitude, around 2% of income, is what you're probably looking at for that. But that would cover. That covers, certainly in the Japanese system, quite a generous system. In the German system, not quite so much.
Sir Andrew, the question that Lord Warner posed.
Well, I think most of that question was really a question for Kate, and so not really for me to trespass onto. It's perhaps worth saying that in the 5 years now since we finished our review, I certainly haven't changed my view about what the ideal system would be, but I have changed my view about how bad the position we're in now is. And the position we're in now is much, much worse. It was bad then, it's much, much worse now. And I do think it's pressing and urgent. It's pressing and urgent for government, because I think if government doesn't act, there's a risk of a very bad crisis. But actually, I'm much more interested in why it's pressing and urgent for people. And it's pressing and urgent for the population, because we live in a country that is now, by historical and international standards, extremely well off. And yet we live in a country where an issue that is likely to face most of us, I used to say repeatedly that the probability of needing social care was higher than the probability of falling pregnant, because half of us are never going to fall pregnant and about 3/4 of us are going to need social care, need it badly. And so this is a widespread issue facing most of us, and the system we have at the moment is inefficient, ineffective, and at risk of becoming defunct. So we really do need to get on with it, and we need to get on with it even if it weren't causing problems for the rest of the healthcare system. It is causing problems for the rest of the healthcare system because of bed blocking and associated matters. So I'm still honestly puzzled as to why we haven't managed to take a bit more action.
Why do you think that's so?
I think, well, I don't know, because I'm not part of that. I'm not part of the decision-making group. I think it's worth noting that I don't think this is simply a matter for the current government. I don't see this being very high on the priority lists of any of the major political parties. It may be that it's because the group that is affected is not a very noisy group, and when the crisis comes, as it comes in many families, it's not a time when people have a great deal of time and energy available for campaigning. So I am puzzled, because I think it is a major problem. I think it's a major problem in itself, and I think it's a major problem for the wider health service, and it would be great if, as a result of the travails of your committee, more were to be done.
Good, we'll come back to that. Lady Redford, you had a supplementary...
Just very quickly, Sir Andrew. We mentioned about funding and funding, extra funding possibly before 2020. Do you think it should be targeted to social care? You alluded earlier to closure of residential homes. I like to think that local authorities have played their part in helping people live in their own homes much longer with extra support, and therefore they benefit by that. And particularly the introduction of the wellbeing hubs as well, where people can go and not feel isolated, etc., and looked after in the community. So therefore, putting you on the spot, do you think if there is any extra targeting of funding, it should go to social care as such?
By social care, do you mean domiciliary care as opposed to residential care?
Yes.
Yeah. I don't. Honestly, I wouldn't claim to be in a position to assert what the proportion should be. I certainly think there are huge merits of both domiciliary and residential care, and it would be very surprising to me if, in the case that there were extra funding, all of it should go to one or the other. I think they are the appropriate setting for different people.
Closure in residential settings is because people are looked after in their own homes. So it's not just not just the funding issue, is
That's certainly true. It is certainly the case that some of, to the extent that residential care homes are shutting because the demand is falling because people are preferring to be looked after in their own homes, that seems to me something entirely to be supported. But I don't think that's the whole story by any means. I think some of the closures are being driven by some of the processes that Kate described and that Julian described, where the funding that's available simply isn't enough to keep homes going.
Okay. Lord Bradley?
Yes, can we turn to the integration issue, which Dame Kate Barker mentioned, and by that I mean the integration of health and social care, but in the context of the wide integration of physical and mental health and wider public sector service reform being integrated into that programme. One, do you think that's achievable? Have you done any assessment of where integration is working successfully or where there are barriers to successful integration? Do you think savings can be made out of such integration? And what do you think the key drivers should be put in place to ensure, if you think it is an appropriate direction of travel, to achieve it more quickly?
The very fundamental difficulty with integration is apparent, which is that the NHS is a ring-fenced budget, and of course social care comes from local authorities and is not ring-fenced and is needs and means tested, and of course the National Health Service isn't. I don't think, however, that should necessarily prevent integration if the relevant local authority and the relevant local health service can be persuaded to put their pots of money together so that they're able to take more rational decisions across it. But that, of course, requires both of them to give up some degree of autonomy, which they're often very reluctant to do. So that, I think, is one of the problems that arises in the system. There are other problems with full integration, which is that they have grown up with two different workforces, and you might need a rather different workforce if you're going to use people to go out who are going to try and combine some of the sort of social care functions and health functions more. Now, of course, that happens today, but you would be doing it much more explicitly, so it's not that easy to get there. Do I think this would save money? I'm sure it would save some money. I would, however, if it were to save money, wish to see it staying in that system. But the primary reason that I believe it to be desirable is not because it would save money. As I said earlier, it's because it would be better for the people involved if they don't have a system that they have to battle with two different organisations at a very painful time. Andrew rightly raised the point, the reason people don't shout about this so much is they're too busy getting on with it. And it would be much better for individuals and their families if the system was more easily understood and delivered to them more effectively and was not so bureaucratic. And that must be the real reason for integration, alongside the points that have already been made about reducing bed blocking and maybe getting a bit more money back towards prevention. It's so we can't. People are a bundle of needs, and we know that, and we're responding to that bundle of needs ineffectually.
I would certainly say it was possible. However, I don't know of any country that has a truly fully integrated health and social care system. Some of the Scandinavian countries come pretty close. Finland, in particular, is one example that springs to mind. And so, I think there are still some differences between healthcare and long-term care that are important to be clear about. And informal care is probably the key part of that equation, the important role that informal care and family play, and perhaps also the range of skills I think Kate alluded to as well, and the potential for substitution for some of the lower skilled tasks involved in caring with what informal carers can do. So I think there are some differences, but also there are clearly some benefits as well. In some of the work that I've been involved with, we've seen benefits which I've loosely placed into two categories. One I think we sort of generally call prevention effects. So, for example, if you do a bit more social care, it helps people with nutrition, with mobility, with falls, which has a preventative effect on their need for healthcare. if you supply the right configuration of social care that allows more timely transfer of care of people out of hospital, for example. So those coordination activities, or preventative coordination activities, are there. And then the duplication issue as well is the other thing. There is obviously a lot of duplication. The needs do overlap to a certain extent, and you get two sets of professionals doing very similar tasks and trying to assess those needs and plan around that individual. So I think there is some scope for cost savings and/or improvements in outcomes. In fact, probably more of the latter, improvement of outcomes than cost savings. It is very difficult to put a figure on this, and if pushed, I think there are certainly some cost savings to be had, but I think they would be relatively modest. Again, I think it's more about improving the way that people experience the system and the outcomes that they achieve if there was a greater level of coordination and integration. And of course, how you do that is another question.
So I think integration is probably a good thing. It's of course been in existence in Northern Ireland for a very long time, and I don't think it's been shown to be any kind of silver bullet. I think it is a good thing for the reasons that Kate and Julian have described, and we should do it, but it absolutely isn't any way of addressing the fundamental pressures either in the healthcare system or the social care system. And the number of people aged 85 and over should double over the 20 years from 2011. That's wonderful. It's absolutely fantastic that people are living longer, but if there are twice as many people aged over 85, the pressures are simply going to continue to grow. And imagining that a kind of instrumental reform, which is good, like integration, might help us address, and might at the margins help us address them. But it doesn't face the key question in social care, which is that there are more of us living, many, many more of us, living much longer, and this is wonderful, actually by and large living slightly longer healthy lives, but we need to look after ourselves as we get older. We have a system that fails to do that, nor does it help us address the fundamental question for the wider healthcare system, which is that demand grows more quickly than the economy. So we're going to have to work out who's going to pay and how. And so integration, I think, is an important issue and something that of which I'm fully supportive. But I think in the context of the questions you're facing, it's a distraction.
Lady Blackstone.
We have to think a bit more radically about this, given that the barriers to integration are partly caused by two completely separate systems, a nationally top-down organised NHS and a local government system which provides social care. Would it not perhaps be better to try and devolve some of the NHS spending and some of its services, or indeed maybe a great deal of them, to local government, so that you could create a more integrated system of social policy more generally, and get the kind of integration that one needs, and also get a more sensible allocation of funding than we have at the moment, where we have these basically in silo systems.
Well, I think you've got to give the money to either the health service or the local authority. I mean, one or other has got to take responsibility. The question as to who it should be, if you're to get a fully integrated system, is one over which I think we could spend a great deal of time. And I think in some parts of the country, I suspect you'd like it to be the local NHS, and in some parts of the country, you'd like it to be the local authority. Whether there's an answer that works across the whole country, I'm not sure. Certainly, it needs to be radical. Although there are some signs of some experimentation in some parts of the country at the moment, where either local authorities or the local NHS is being willing to give greater delegated authority to their counterparts. So I'm not deeply pessimistic about it, but I don't think it's going to answer the core question that this committee is trying to answer, which is how can we move to a more sustainable system in the long run.
Can I add? I think when you talked about devolution, one of the things that struck me was actually all the way down to the individual in the form of some form of personal budget. We did a large evaluation of personal health budgets a few years ago, and my colleagues have worked on personal budgets in social care. And actually at that level, what you saw were two things: people engaging with their personal budget, but also a shift in what they use their personal budget for. So you did see more social care, if you want to use that term. You saw more sort of well-being services and perhaps less of the traditional mainstream services. So where this seems to have had some traction is where it's being pushed all the way down to individuals. And I completely agree with your points that the organisations at the moment, the way they stand, they're organisationally different, their funding is different, their culture is probably different. And so it's not surprising that we haven't seen as much integration as over the years as I think people had expected to see when first looking at this issue.
Tim, Kate, do you have any comments?
No, I think it's been very adequately covered. I'd like to support the comment about personal budgets, because I suspect that means that money gets spent better in terms of the outcomes for the individuals. But administering personal budgets is not, put some cost back into the system and put some cost onto the individual and their families themselves. But it does seem to me a desirable thing to do, because I want to go back and pick up some points I think other people have made. One of the things that perhaps we haven't talked about so far in this session is how we think about carers and the voluntary sector. And I think none of us would want to feel, we wouldn't wish to be responsible for our elderly relatives, but the fact of the matter is that many of us live a very long way away from our elderly relatives, which makes it, frankly, much more difficult. And Julian sort of referred to this obliquely, I think, when he's talking about family circumstances changing. If you look back at the post-war settlement, I imagine that the assumption was, firstly, people didn't live so long with needs such as dementia, and I imagine the assumption was that they would be cared for within families where there were fewer working women. That is no longer the case today. So we need also to make sure that we try and make a better offer to carers, and my understanding is that following the care bill that hasn't really happened as much as people hoped. Carers don't feel they're any better supported, and actually supporting carers better so they were clearer about having, how much they could expect to have the burden lifted from them in a physical sense, might make people more willing to undertake it in the first place. Caring must feel terribly lonely for a lot of people, and we mustn't lose sight of that, because I think rightly we all know that lots and lots of informal and voluntary care goes on. Ensuring that we're able to get the best out of that seems to me very important.
Lord Warner.
Have we made a mess of the boundary between health and social care? And this is particularly a question, I think, for Julian Forder. Are we out of step in comparison with international opinion in similar countries in having nursing homes not part of the healthcare system? And how much out of step are we with that? But then turn that on its head. And are we fighting a losing battle of keeping continuing care in the NHS? And should we not be transferring it clearly to actually social care and capping individual liability? But at the moment, we've got neither fish nor fowl. It seems to me a bit of a muddle. What are your views on trying to straighten out that muddle?
Well, I think my first response will be there will always be a boundary issue wherever you draw the boundary, of course. And I think that it's been helpful, I think, to break the type of care down into its various components. So, broadly speaking, you have acute healthcare intervention, you have nursing care, personal care, and then practical, long-term and well-being type services. And it seems to me that if you can get your fault line at the junction of those components of care, that would work better. And certainly, if you try and draw the fault line in the middle of what constitutes personal care, that's going to be incredibly difficult to sort out. And I agree that the way in which NHS continuing care works is difficult, and has proven that there are some significant boundary issues. On the other hand, I'm not sure that those would improve necessarily if you pushed the boundary one way or the other. It might even be more difficult if you pushed it into what people consider to be personal care to a greater degree. I would say that there are certainly some issues around the way that those services are funded, and I think both Kate and Andrew have picked up in their reports, and we previously, when I worked with Derek Monless, all talk about the accommodation issues with NHS continuing care, and I think that one is something that could be addressed and should be addressed.
Are we out of line on nursing homes with international opinion?
Well, in some respects we are, but I would also, I think Baroness Redfern's point made earlier that actually it's not necessarily a bad thing to be moving away from residential care. If people want to live in their own homes and can be supported to live in their own homes, that's a good outcome. And so taking one form of care, one with residential component, i.e. nursing homes or care homes, and putting it into one system and then leaving home care in another system, I think could create perverse incentives in that regard.
What happens in Scandinavia? I mean, you said that there was a more integrated system there.
Yep, it is closer.
Just tell us a bit about how it works, and surely it's relevant to Norman's question too.
Yes. So if you take Finland at the moment, most of health and social care is organised at the municipality, the local authority level. More specialist hospital care is distinct. So there is closer integration in that respect. I think that getting this balance right between the residential and the home care is important, and it would concern me if that was where the boundary line was drawn, because although obviously a person's in an institutional setting, if they're in a nursing home, the combination of needs that they have doesn't have to be different from where the person is supported intensively at home. So it strikes me that if you take a needs focus and an outcomes focus, then that's an artificial distinction to make. I don't think anywhere's got this absolutely sorted out. I think that, I would certainly look at the experience of the Scandinavian countries, but there again, lots of the other countries that I mentioned earlier, France, Germany, other places do still maintain a distinction between their health and social care systems.
Okay.
The health service is actually now taking the law into its own hands. It's actually buying, and even being encouraged by Lord Carter to build nursing homes to get people out of hospital. So are we fighting a losing battle here? I mean, if you have a collapse of the publicly funded social care, do you end up force majeure actually with nursing home being a better option in the NHS than keeping people in the medical wards of acute hospitals?
I mean, certainly you would want to see greater coordination, and so people now began to talk about different models for that. So the Accountable Care Organisation is one where you see responsibility for a greater part of the spectrum of care needs being afforded to one organisation, and it seems likely that there are some gains to be had by improving coordination between systems. So delayed transfers of care, obviously a very topical issue at the moment, and an improved level of coordination would seem to produce benefits, would seem that would be a good solution. How you achieve that, though, whether it's health, assuming some of the responsibilities for those social care or personal care responsibilities, or whether it's vice versa, the other way around, I think that is a question which many people have struggled with, and it's a complex one.
The whole discussion that we've been having for the last half an hour or more come down to one thing, which is appropriate funding of the social care sector. And that if we don't do that now, would you agree that if we don't do that now, it will have an impact on long-term sustainability of the NHS, including the acute sector? And what is it that we do need to do now?
I think the answer to your question is yes. Yes, but actually it is already having an effect on the sustainability of the wider NHS. So I think we do need to act, and I think the need to act is growing more pressing month by month. And at the moment there is inadequate funding to deliver acceptable levels of social care provision in England, and that is having an effect on the NHS itself. And some of the developments that Lord Warner talked about are a reflection of that. We are now seeing some major acute hospitals trying to organise the funding of care homes, because that's the only way they can imagine they can get people out of acute beds into more appropriate care.
So is it your view that currently the NHS is suffering because of lack of social care?
Yes.
And that the lack of the long-term sustainability of the social care is more important to make NHS more sustainable in the long term?
Yes.
So how would you achieve long-term? Is your recommendation, if adopted, will achieve long-term sustainability of the social care?
As long as, so I think putting a cap in place would certainly help, but one of the things we were extremely clear about is that you also have to have adequate funding of the means-tested system. So there are two separate questions. One is, how can we make a social care system that will function and take away the fear and anxiety that affects the whole of the population? And the second question is, how can we make sure that those who have no or very little resources of their own are adequately looked after? And to deal with that second question, you have to have a means-tested system that is adequately funded. To deal with the first question, which I think is crucial for the long-term sustainability, we have to take away from people the fear that they face catastrophic costs over which they have absolutely no control. Social care is the last big risk that we all face, over which we can do nothing but shut our eyes, put our fingers in our ears and whistle bravely. And that doesn't seem to be a very sensible place to be in 2016.
So are you saying that the key thing about a long-term sustainability of NHS is a proper level of funding?
No, I'm certainly not saying it's sufficient, nothing like sufficient. I'm saying it's necessary. If we don't sort out the social care system, the NHS will continue to face this constant problem. But the long-term sustainability of the NHS, I think there the issue is, how do we balance the way in which demand grows much more quickly than the economy? So I think it's a separate question, but we won't be able to answer it adequately unless we tackle the social care problem.
Lord Warner.
Can we just take the logic of that through, Andrew, and possibly the other members? I mean, if we don't, as a country, fund adequately means-tested social care, and we don't cap catastrophic costs for people, do we end up with a situation in which the demands on the NHS become so large that you have to tackle the issue of whether it can continue as a tax-funded, free at the point of need system? Is that where this logic takes you?
I don't think that. I mean, I think in extremis, yes, but actually I think there are other pressures facing the NHS that are hitting it even more quickly on the grand scale than this. But yes, if we don't have an adequately funded means-tested system, then we'll continue to have bed blocking, and that's getting to be a more and more serious. And if we don't have some system that allows all of us to help take control of our own social care needs, then we will have many more people ending up in the NHS with falls that could have been prevented than, for example, than we otherwise would need. But actually, I think the wider problem for the NHS is that in 1955 we spent 2.9% of GDP on the NHS. 10 years later it was 3.4, 10 years later it was 4.6, 10 years later it was 4.5, 10 years later it was 5.2, 10 years later it was 6.7, 10 years later it's 7.4. It goes up. It's rising at 1.6% a year, more quickly than the economy. That is, and there have been two occasions in the last 30 years when governments have tried to stop that increase. One was in the middle years of the 1980s, and after that, in the late years of the 1980s, Mrs. Thatcher's government substantially increased spending on the health service because they felt it was unsustainable. The second was in the middle year of the 1990s, after which we saw the Blair-Brown very substantial increases. These pressures are seen throughout the developed world. I don't see any reason to think that they will go away. Of course, we can do better integration. We can try to make the system more efficient. There will always be ways of making it more efficient. But there is a long-run upward trend in the amount that we want to spend on health services, including social care. We change the allocation of our spending very readily in the private sector. So we've gone from spending 4% of consumption on transport to 12% of consumption on transport as private individuals. We want to do the same with health. We haven't yet found the way of doing that. There are essentially two options. We can either go on with a tax-funded, free at the point of use healthcare system covering it all, in which case taxes will have to go on rising, or we can try to find some other way. And it seems to me that's the central challenge facing your committee is, if you don't believe that taxes will continue to rise, how are you going to square the circle?
I think that's right. I think that in the way you put it, the question was a bit odd because I completely agree with Andrew. I mean, in some sense, you're asking a question about both systems together to say if we don't fund the social care system better, will we find the NHS funding falls over? I mean, what you're really saying is, I think implicit in that is we have to fund the social care and the NHS both better to meet a decent standards, or the money has to come from somewhere. And in a way, in social care, I find it more compelling in some sense than in the NHS. In the NHS, we could always choose not to take fancy new technologies or more expensive drugs and, let people die. In the social care system, people with dementia will kind of carry on living pretty much regardless of what we do to them and ought to be dealt with decently. That sounds terribly hard. I know it sounds terribly hard. But these are the kind of choices that you have to think about. So if when you say, I'm not quite sure what you mean when you say, what's the sustainability? If you're saying, do I think the NHS, as people would like to have it, free at the point of use, with the present level of GDP going to it, is sustainable for the next 20 years, then I agree with Andrew. It absolutely isn't. We will only be able to have an NHS free at the point of use that meets what people would really want out of it if more money goes in, which either means that we have to introduce charges in some way, or that we raise taxation. This seems to me a very profound political choice. Now, this is made more difficult for the NHS if we don't fund social care adequately. But the reason we should fund social care adequately is because it's not decent and humane not to fund it adequately, for me. The question for the side effects on the NHS are, of course, undesirable. It's very inefficient to have people in acute hospitals when they could be looked after probably better, and they'd probably prefer it in a less expensive way. I mean, I think the tragedy of having people stuck in acute hospitals is it's neither good for them nor the hospital. So it's sort of doubly awful, and clearly we should get rid of that. But the problems of funding will persist even when we have removed that issue.
The honesty of my question, just to be unclear, I'm trying to provoke you to say what you've said, because I am a sceptic about politicians' willingness to actually increase taxes, with the demand going on and on and on the NHS.
I recognise that.
But I successfully have provoked you.
You've got that. Yeah. So good. That's a good. That's a result for both of us.
From Andrew on about the funding, it's increasing year on year. Nevertheless, the population is growing, and the ageing population, and we want to see the ageing population living well without any major concerns, but which there are at the moment. But also, with the funding to target on social care, I think is really important, because it has a financial help with the acute trust, so we can get people out of those beds as quickly as possible, and therefore the local authority, with their intermediate care, is a step to really help them get out very quickly, and then probably on to their own home. So I think there's like a three-stage step as such. And I think it's just vitally important that we treat people as individuals, and I'm very pleased that we have personal budgets, and we did debate last night about disability and help people with a disability with their personal budgets have real choice and so they help to integrate into the system as such as able-bodied people. So going back from there with the funding to social care, it would be interesting, the three stages: out of acute as soon as possible, because we all know people live in acute beds much longer, lose the confidence to go home eventually. But it's about the intermediate intermediate care that's the real help that we want to probably focus on and improve.
Well, when we're looking at that particular set of issues, yes. But of course, social care isn't just about taking people out of hospitals and getting them back into their homes. Yeah. A lot of social care, at its best, will be about helping people take control of their own lives so they don't end up in hospitals. So what the optimal mix is a delicate term of art, the question of art, and I certainly defer to Julian, who is these days much more expert on that than I am.
Yes, I think that was a very important point to make. And we've been doing research recently and trying to measure the impact of social care in its own right. And I think that is a crucially important part of the debate. And a lot of the focus of discussion recently has been on the interface between health and social care, but I think it's very important to think about social care in its own right, as well as having these additional benefits you could see coming from greater coordination. And a lot of people rely on that. It improves people's quality of life. We have quite a body of research now showing that social care does that. And so it's important to keep that in mind. It's important also to link with informal care, as we've mentioned before. And if we're talking about integration, then we're talking about a sort of social care in its broadest definition, then you're talking about housing, criminal justice, benefit system as well. Yeah. So all of these things need to be considered, not just the sort of interface between the health and social care system.
Thank you very much. Alice Blackstone, you have a question.
I just want to end by asking whether you have a key suggestion for change that the committee could recommend that would support a sustainable NHS.
I've got two. Cheating. So my first is try to create a serious debate. Try to create a serious debate about this. I've been working in this area for 35 years. In fact, I think I first gave evidence to a parliamentary committee about this sort of issue in 1983 to the Treasury and Civil Service Select Committee on. I think we are lacking a serious debate about the kind of choices that the three of us have tried to describe, and I think that's going to be crucial. And the second thing that I think we ought to do is actually make sure that the government does introduce a cap on social care while at the same time properly funding the means-tested system. I think those were things that were agreed, were legislated for, were in the government's manifesto, and so I'm very much looking forward to seeing them done in 2020.
It's pretty difficult to say anything after that, so I won't. I completely agree with that. I think Andrew is correct. It isn't just about the cap. It's also about entitlements. We argued very strongly in the report that the entitlements between social care and health care are kind of bizarrely different, and that's a trouble. But we have to accept, as I say, that we probably can't fund everything out of general taxation. People are going to have to cope with some of the ups and downs in their lives with social care as we do with other things, but they shouldn't have to cope with catastrophic costs. And people who have not got the resources to cope should not be left without any, as I think is happening too much today. Julian referred to this earlier, and the fact that actually we don't really know what has happened to all these people who are no longer getting local authority care. We don't quite know how they are coping. I think that is terrible. So I think I completely agree with Andrew. The main thing we have to do is have a bigger and honest debate and develop a sensible longer-term plan towards this and stop producing little bits of sticking plaster that kind of just paper over the cracks. We just can't keep papering over the cracks.
Can I also indulge in two? I think one is certainly about the funding of social care. As I think I said at the beginning, I think it's time to now look more seriously at statutory insurance and some form of hypothecation. There's been, since the Royal Commission in 1999, many attempts to reform social care. So I think now statutory insurance is something to look at very closely. And then the other is coordination. And obviously they are linked, as we've been discussing, but I think there's a lot of coordination activity that could be done, not least much better information sharing between the health service and long-term care, which I think has become very difficult recently. joint care planning assessment. There's lots of organisational and delivery type things that can still be done that will improve that, even if we do operate with the same envelope of funding.
Well, thank you very much. Thank you, Jim Kate, Professor Forder, and Sir Andrew, for coming today and giving us your time in a very important session. If you do think that there is further information about something that you certainly thought about, please do send it in, and we will have it as an evidence. So thank you today for coming.
The proceeding has ended.